Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager from the IMST based in DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Good afternoon, Margaret. Good evening, good night, actually, to some of our colleagues who are currently in Tokyo, where, if I'm getting well, is 10 p.m. and some of them might be looking at our press briefing. And good morning to all the colleagues. It's really a pleasure for me today to come and on behalf of our DJ one more time to say a big thanks. There's been 1 year since the declaration of the facts and the fact by WHO. And during that year, all of you, the journalists, have been following us, have been supporting us, have been ensuring that we send the right information to our community, to our leaders. But also thanks to all the colleagues from the IMST, from the member state, from all the different partners, the community health worker, the doctor, the nurse, and all of you who has been in the field ensuring that we are the most efficient in the way we respond to this Mpox outbreak and to others. Over to you, Director. Thank you. So as mentioned, I will be doing the press brief on behalf of our Director General, Dr. Jean Casea. Next slide. Who a week ago was in DRC to support the response that the country is providing to several outbreaks, which include Mpox, but also cholera, also measles, amongst others. And one of the key tools that is needed to reinforce that response is to ensure that the EOC, where the response is being monitored, is being managed, has the adequate equipment. So they've managed to do a handover ceremony where they provide some medical and IT equipment to the Honorable Minister, Dr. Roger Kamba, to strengthen the NPHI in the way they're responding to the different outbreaks. To note that the NPHI is quite new, it has been there for some few years now, and they've been able to take the leadership to response to the Mpox outbreak and the cholera that is ongoing. So there is also the opportunity to have some high-level strategic meeting held to intensify the effort against cholera and other epidemic threats. It was also the opportunity at the highest level to get the commitment of the DRC in terms of supporting the Africa CDC epidemic fund to an estimate of around $5 million that the country will provide to Africa CDC, which is following the support that we've received also for Angola and for other member states. Just to highlight that the domestic financing of our institution is been moving, and DRC is really a good example of this progress. Next slide. It was also the opportunity last week to strengthen the partnership with the UK Africa CDC collaboration. In this response, we've been able to work with some colleagues from the UK HSA in the side of the IPC, Infection Prevention and Control, also in the lab, in the case management. So this strong partnership is an opportunity to reinforce what the new public health orders, where we have a strong African leadership, but we also have that global responsibility with those strong allies. And the discussion were around the pandemic prevention and local manufacturing, the health financing, and the digital health. So it was also reaffirmed the commitment to deepen the UK Africa CDC cooperation on the response to outbreak, but even more broader. Next slide. As I mentioned in the introduction, the Director General is currently in Japan, attending the 9th Tokyo International Conference on African Development. the TCAT-9. This is an opportunity to have a head of state and government engage with the government of Japan. In a time where the global health, the new era in terms of financing, is critical to ensure that we have those new or we strengthen some of those partnerships. And the government of Japan, through its leadership, is really willing to push more on the health security collaboration. So during those 3 days, the discussion are around how to transform the agenda, which include the local manufacturing, which we know Africa CDC is really a pioneer in pushing, but also digital health innovation and climate resilient health system. Next slide. Since yesterday, we had the stock taking Continental on Mpox research and emergency response, which is still ongoing. So this is the time where our researchers working on Mpox pause to assess how far they have gone since the Mpox outbreak has started. So there are more than 130 scientists, but also the NCN manager, the ATCs, the regulator, to ensure that we have the entire continuum of the response. So ensuring that the research that is being implemented actually impact, improve, and make the research more efficient. And around the table, we also have the funders, the partners, CP, EDCTP, and others to ensure that we have a comprehensive approach to assess where we stand, but also agree on the way forward. So it's the opportunity to support the emergency response and focus on collaboration among stakeholders. Some few questions around how also to implement research early enough within an outbreak, so that we've seen occasion during Ebola or previous outbreak when the research was delayed, and therefore we meet some opportunity to assess diagnostic, vaccine, and others. Here, the discussions are around how within 5 days, maximum 2 weeks, we can have all the ethical approval that are needed for the research to be implemented so that it impacts the response, but also how the research uptake is being implemented. So there are also some critical discussion about the operational research role and the development of continental framework. How can we address as a continent research during outbreak and beyond? How can we get domestic funding so that the continent has an ownership of the research agenda, but also of the output of the research? And this linked or is connected to the pandemic agreement, where we are discussing, debating how the produce of research, of sequencing and others, which are translated in new diagnostic, new vaccine and others, really benefit to the population that have been invested, integrated and used during those research. So it's really a great time for the researcher to move from the intensification or the research toward the legacy. Legacy in terms of operation, but also in terms of research outcome on social behavior, how the Mpox have changed our community, how our community have responded to it, and how our intervention has been efficient. Next slide. So coming back to our public health events, we still have those top 4, cholera, Mpox, measles, and dengue that are affecting our continent. And we have countries like DRC, Kenya, Uganda, Ethiopia, that actually have the triple pain, which means they have at the same time cholera, Mpox, and measles, and they have to find ways of being more efficient using the tool they have, which include the NPHI, to ensure the most efficient use of the resources that are scarce, but to provide adequate protection of their population. And as we see with the number of the different events, the high risk and the moderate event, we are more than half of what we've seen in 2024, highlighting the fact that we have more and more of those events, whether moderate or high risk, than the previous year. This most likely also is an impact not only of the climate change, but also with the insecurity that we've seen in some of our countries in the continent. Next slide. Now, coming to the situation of Mpox in the continent. So we are glad that we continue to see the decrease of the number of suspected cases. You can see from 3,000 last week, we are going down to 2,483. Same thing for the confirmed case. But the challenge now really rely on the number of deaths. You know, the case fatality ratio is one of the critical points on the management of the outbreak. At the continental level, we are still below 1, actually 0.5%. But you will see later that in some countries, we are around 1%, if not more. So which is this week highlighting how critical it is to implement intervention to support countries, member states, to ensure that the case management is optimal so that we really go far below the 1% target. So there are some good news that we can see also on how we manage the outbreak. We can see the reduction that I've already mentioned, but the increase of the testing coverage. You've been following us for many weeks, many months, and you recall the time we were alerting the very low testing coverage of around 20%, 13% sometime in DRC. Now we are around 60%. So we are more confident saying that out of 10 suspected cases, at least 6 of them are being tested. In some countries, it's actually 10 out of 10. So that is an important development. And as mentioned, the main challenge now, our focus is really in terms of the reducing the number of deaths. Next slide. In DRC, we continue to see the decline in terms of number of suspected cases, but also in terms of the confirmed case. We've seen from the peak a 60% decline. But what we are also seeing is a shift in the outbreak, moving from Kinshasa, moving from the North Kivu. We can see an increase of cases in the Sankuru, Bawele, and Tanganyika. So that way, the community healthcare worker, the intensification, and with the different partners is now happening to ensure that we also surround. And as we come later, also, those are some of the places where the vaccination with the LC16 vaccine is been happening to ensure that we really move toward the end of these outbreaks. So interestingly, there have been some detection of Mpox in dogs, rats, bats, and squirrel in the Equator and the Tropical province, which remind us that though the human-to-human transmission is one of the key drivers because of the clade 1B and the clade 2B in the continent, the One Health approach still remain, because finding Mpox in animal or some of those domestic animal highlight the challenge of the transmission between the animal and the human. Next slide. In Sierra Leone, we can see that the operation zero case by end of August is moving pretty well, though they might need to extend as there is only 1 week remaining. And this week we have 43 new cases as compared to 102 last week, which is more than around 60% of reduction. But as you see also, and as mentioned, the biggest challenge here is the number of deaths. Altogether, we have 50 deaths since the beginning of the outbreak in Sierra Leone, a case fatality of almost 1%. And this week, we had 3 deaths as compared to 1 last week. When we visit that, we appreciate that one of the biggest challenges is that the people who will pass away because of Mpox also have other comorbidity, including HIV and so on. And then we agree that we should strengthen the support with other actors like Dr. Without Borders on the specific support of those patients having comorbidities, so that while the government and other actors are really focusing on the surveillance and the vaccination, they can take on the side of the care for those specific patients, not only when they are already in the late stage, but early enough where something can still be done. The country is continuing the vaccination, and 43% of the people vaccinated are contact, which has been a big shift from the beginning, and ensuring that at this pace before they start the next round, which will be, I believe, in a week or two, they will have a better way of seeing the new face of the country as the Mpox case are concerned. Next slide. In Uganda as well, we continue to see the decline in the number of cases from 83 to 71, but also in the number of suspected cases, a reduction of 14%. But still, Kampala, Wakiso, and Mbarara account for the majority of the confirmed case. The death also has 48 have been recorded among confirmed cases, nearly half of them, 48%, occurring in individuals infected with HIV. So similarly, like in Sierra Leone, the management of people living with HIV is critical at two levels. One, at the level of being the target or the first people to receive the vaccine, but also in ensure that once they are isolated and managed, they have a holistic management, which will include the management for Mpox, but also for HIV and other comorbidities, which of course include all the laboratory investigation that has to be made free for those patients. Next slide. In Liberia as well, we keep on seeing actually a drastic decrease in the number of suspected cases from 124 to 31, more than 75%, which we also see in the confirmed case, 77 to 19 this week, by still confirming a testing rate of 100%. So which is quite important. The test positivity rate is remain a bit high, around 60%, while we would like to have it around 30%. This is a good indicator that the surveillance within the community is active, and then we catch all the cases early enough at the level of the community. So they've just reported the highest number of cases in the last 6 weeks, but as we see this week, as we've seen an important drop in the case. So now one of the way the response is happening is the home-based care, where 90 out of 97 patients are isolated at home, with 7 in health facility. This highlights the need for proper surveillance of the people who are isolated at home, because we've seen in some other countries where it has not been working well, where patients, when they're supposed to be at home, we start seeing them elsewhere spreading the disease. So it's critical to ensure that whenever the means are possible, to have to isolate in the health facility, as most of the country are now doing, from the lesson learned from the first week, the first months of the outbreaks. Next slide. In Burundi, we are seeing a slight increase in the number of cases from 32 to 45, which goes along with the enhanced surveillance that is currently happening. You remember that at some point, the number of cases was really low around the week 22, and the government has decided actually to strengthen, to boost the community-based surveillance, which we believe is producing those that increase in the number of cases. And seeing that the same method will definitely be useful, one, on isolating all the positive cases, but also on adjusting the messaging, especially in the population that consider that the outbreak has ended. It's important to remember that it is still there, and that the measure need to be implemented as they used to be. They have a very good investigation, with 95% of all that are investigated. This really signals a strong active surveillance, and it's quite reassuring on the way the country is actually engaging the response. Next slide. In Ghana, we are glad to see the stabilization, slight decrease in the number of suspected cases and confirmed cases, because this is a country that we were following in the last few weeks, when we were seeing that increase. It has reported the highest number of confirmed cases in the last 6 weeks, with an average of 35 confirmed cases per week. And when we look at the 2,000 cumulative contact, only 2.4% tested positive for Mpox. This is a challenge in the way we are implementing surveillance. The way we implement, we believe that for one case, we will have around 20 contacts, which most likely will be in the same household. But with the Mpox, which is a sexual transmission disease, where it is very difficult for the contact to actually disclaim, for the case to disclaim the contact, we end up having, in many occasions, the wrong contact. That's why the strategy for surveillance, but also to vaccination, has to be adapted to this new disease, but also to the challenge that it brings in terms of social, but also in terms of stigmatization. Next slide. In Republic of Guinea, so we've been as well following the recent increase in the number of cases. This week we have a slight increase from 77 to 78 confirmed cases. We have a decrease on the suspected case. But when we look at the test positivity rate of around 80%, we believe that we are missing a large number of the patients who are in the community, because the 80% of test positivity rate mean that the people that are tested and therefore are positive are those who already have an advanced level of the disease. So at this point, the IMST is planning a visit and a support to the country so that they can really strengthen the surveillance on one side, but also increase the capacity to isolate all the positive patients, so that those ones are really breaking the transmission chain by being isolated in one side, but in the other side also ensuring that they have the holistic care, which include the mental health, but also the feeding, not only for them, but also for some of their caregivers. So as per now, the outbreak is concentrated in Conakry, Farana, and also Kindia region. Next slide. In Zambia, we are seeing a small increase from 11 to 15 confirmed case. The test positivity rate has decreased to 80%, so which means that they are quite aggressive actually on the surveillance, which is a good signal. They've also reported the highest number of confirmed cases in the last 6 weeks, and the majority of those have been detected in 4 districts, which is Lusaka, the capital, Mufulira, Mkushi, and Shindamo. 11% of the listed contact tested positive. As you can see, it's much higher than what I've mentioned previously. And also linking to the test positivity rate, it's given a good sense that they are managing to track and to get the right contact. So now that they've received some few doses of vaccine, it will be important to ensure that the vaccination strategy really target the key population. Next slide. In Kenya is at this stage one, if not the country that is the most worrisome on our side, though the number of confirmed cases remain around 36 from 33 last week. What we see is, one, the case fatality ratio we have is around 2%. We have 7 deaths for 347 confirmed cases, which is quite high. Now, the other challenge is that the outbreak has been happening in the coastal. Now, we can see that Nairobi is the 3rd highest contributor of case with 8% of the case. With Mombasa, Busia, they account for 69% of the confirmed case. And we know that when the capital city is affected, and we know that the spread can actually be exponential. So that's also one of the reasons why we are fast-tracking the support that we'll be bringing to Kenya, including a country mission that will happen in the next few days or few weeks. We have 3.5% of contact tested positive for Mpox, highlighting that in that case as well, we might have some of the right contact that we don't capture through the surveillance system that we are using. Next slide. Now, in terms of vaccination, some key progress has been made. We have delivered 3.1 million doses of vaccine to 12 countries. Quite a number of them, 8 are successfully vaccinating, but we have new countries like Cote d'Ivoire, Nigeria, who are starting the vaccination or resuming. We have the good news of the US government that authorized the shipment of 219 doses of vaccine that will go to Malawi, Ghana, Sierra Leone that have already completed all the conditions for shipment, but also for other countries that are in the process of getting all the documents that are required for the shipment to happen. Next slide. So in DRC, where the IMST is located, the launch of the LC16 vaccination has started on the 12th of August. And since then, 28,000 people has been vaccinated in Kinshasa, but also Makala, Bumbu, Kololo, Limete, Lingwala, within Kinshasa. Those are really the hotspot. Now the challenge that the next step will be to move out of Kinshasa. And as mentioned, we have those provinces on the side of the Sankuru, Tanganyika, and so on that will definitely benefit from this vaccination. Next slide. Now, moving from Mpox to cholera, as you can see, the number of cases are still increasing. And at this rate, we will definitely go beyond the 254,000 cases that we have in 2024. And the key member states are listed here. So next week, the Continental Cholera Preparedness and Response Plan will be launched in Lusaka by the chair, the champion actually of the cholera response for the African Union and Africa CDC, the president of Zambia. And this is a tremendous work that is being done not only by WHO and Africa CDC, but by all the different partners who have sent their perspective on how the response to cholera should be. The partners, but also the member states that have also highlighted the way they want the response to happen. So the plan and the task force will be launched next week in Lusaka, as mentioned. Next slide. So in terms of country, we have the Congo that is now seeing a decrease in the number of cases, with still some few challenge in the healthcare, particularly in affected community. The implementation of ORS and the need to ensure safe water, strengthening hygiene messaging are really the key activity that are going on as we do speak. Next slide. In DRC, we are glad to see the drop from around 30% from 1,826 cases. We are going down to 1,231. From 84 deaths, we are moving to 50, which is already a good indicator of all the effort that has been put in place by the country, the NPHI, and all the actors of the response. However, we still have some challenge in the side of Goma, also the flooding that has happened in Chopo, that might actually challenge the ongoing decline that we are seeing. Next slide. In Angola, we are really moving toward the end of this outbreak, so which is also an example that when all the goods, the human resource, the vaccine, and the strategy is present, then we can get rid of the cholera. But now the question is, these outbreaks, we are going toward the end, but how can we sustain some long-term goal in terms of implementing the infrastructure so that the population can have a proper access to clean water? So the support that has been done in terms of training healthcare workers, in case management, surveillance, and IPC, and also the financial support to medical work is great to stop the outbreak. But now we are really thinking of how to move further than that. Next slide. In Chad, as compared to all the other countries, we are seeing a significant and exponential increase in the number of cases and deaths as well. You have a case fatality rate of 6%, with 17 deaths this week as compared to 6 last week. So the driver in Chad is really driven by conflict-induced displacement. So again, going back to the challenge where when there is no peace, it's very difficult to have a proper health in those camps. You have overcrowded camps with inadequate sanitation, seasonal water contamination, and a limited access to clean water. So on one side, we need to ensure that we have the peace so that we can have access to the patient. Now we're talking about Chad, but they're coming from the neighboring country, and we need to support the charge on scaling up the finding and case finding and treatment, the vaccination, which is key. And as we see in Angola, when the vaccine are available and the resource as well, then we can bend the curve of the outbreak. So we also need to ensure a steady supply on ORS, which are critical tool and item to take care of the patient exposed to cholera, along with prepositioning cholera kits in neighboring health district. Next slide. In Ethiopia as well, we are seeing the decrease as compared to what we've just presented in Chad, and a decrease gladly in number of cases that reduced by 50%, but also the number of deaths that significantly reduced. You can see that the case fatality ratio is 0.9, so below the 1%, which is great. So now the hotspot in Gambela and Amara region are really the one to prioritize in terms of providing access to reliable pipe or chlorinated water and communal latrine, but also and once again support the conflict-affected zone in this area of Amara, and that will be done with the mobile clinic and the wash facility. Next slide. So in summary, we see a sharp decline in Mpox case since the week 19. The vigilance remain essential because you've seen that we have different categories of country. We have those where with Uganda, DRC, where we see the decrease, but you have country like Kenya where we see an increase, and the fact that there is a shift from the coastal border to the capital city, that really emphasize the need for vigilance and to quick support of the member state. In terms of surveillance and laboratory, we see some great improvement, which is highlighted by the testing coverage, which is around 60% from 20 to 30% at some point, which also ensure that the response is faster and more efficient. In the first week of September, the ECG and the IHR, which are the consultative group of the Africa CDC and WHO respectively, will meet and assess where we stand in terms of the facts and the facts. So they will decide whether it's needed to lift and what are the recommendations if that's the case. In the meantime, at our level of the IMST, we are working with our partners and also will engage with the member state on the transition guideline, transition plan on what will happen once the fact or the facts are lifted, or for countries that are getting out of the outbreak, how to integrate them in the national system. For cholera, it's remained a major threat in the continent. We've seen a country like Chad where the cases are increasing. We see Angola and others where they are decreasing. So for this outbreak, we might be in a good place, but we really want to have a comprehensive way to look at the sustainable elimination of cholera by 2030. So that's what will be launched next week in Lusaka. Both the Continental Task Force that will be chaired by the champions, the president of Zambia, and also the Continental Preparedness and Response Plan Cholera in Africa 1.0. So with that, I will hand it over to you, Dr. Margaret, and we'll be happy to take some questions if our colleagues that are here and those who are online.
Thank you very much, Prof. Let's take the first two questions. I have one here from Ruggiero of the RCC Media Group. The question is, in light of USAID funding reductions under the Trump administration, what specific impacts are you seeing or projecting on Mpox prevention and containment? That's surveillance lab capacity, vaccine procurement, cross-border and rapid response. That's the first question. The second question comes from Augusto Morel of the Spanish news agency. The question is, what is the latest update in terms of vaccines for Mpox? Has there been any new arrivals? I'll take that back to you, Prof.
Okay, so on I will respond on the first question on the USG funding, and Dr. Charles will respond on the vaccine update. So for the USG, the impact of the US government, we've seen it first of all in some countries where it was more exacerbated, because that's where the US government was having the most important support. Uganda, a part of DRC with the USAID, and also in some specific pillar, a specific activity, including the surveillance, the lab, and so on. But along the way, with the resilience of the country and also the reorganization of the other partners, there has been some alignment and more resilience. So as per today, as mentioned, there are some discussion ongoing in Japan. Korea also have been there to increase their support. So we should see how it will go. In the other hand, as we mentioned for the vaccine, the US government has authorized the shipment of 219,000 doses of vaccine, showing that there is also some good, the partnership is moving toward good direction. So let's see how things will go. They have also, the PEPFAR have also been continued. So I think we are confident, we are optimistic actually, more optimistic on the future of the USG support. So for the question of vaccine, I will have my colleague, Dr. Charles, that will come closer to me and answer the question on the update for vaccination. Over to you.
Okay, thank you so much, Prof. So just to give a brief update. So from this week to last week, there have been some quite increase in terms of the deployment of the vaccines, though not too much per se, because it's a bit slow now. But we did see in DRC that vaccination has, kick-started, especially with the LC16. And then we did see in countries like Nigeria now, they've started revaccination. And so far for LC16, about between 24 and 28,000 has been deployed, have been vaccinated, persons have been vaccinated for LC16. And then in Nigeria, about 5,000 have been vaccinated in this new phase. Then in terms of shipment, we've also seen improvement, because we now have, of the 7 countries that was allocated in the 5th round, we now have the go from the USG, as Prof did mention, for 3 countries. And hopefully by next week, we'll be getting some ETAs on when these doses will arrive. We believe this will mainly boost the numbers in the country, and also help to, for better coverages to support countries moving forward. Thank you so much.
Thank you, Charles. Over to you, Margaret.
Thank you. Let's cross over to the floor. We have Gabriel Emmanuel from NPL. Gabriel, you have the floor.
Thank you very much. And I'm sorry, I missed a little bit at the beginning, but I was wondering if 2 things. One, if you could say a little bit more about what is driving the shift and change in the Mpox in Kenya. And second, you were just mentioning PEPFAR and the cuts to US funding. I wanted to know how things are going right now with access to HIV/AIDS medications, if that's something you're able to speak to. Thank you very much.
Thank you, Gabriel. Back to you, Prof.
Yes, thank you, Gabriel. So what we were saying about Kenya is initially the case were happening in the coastal, in Busia, Mombasa, and so on. That way we were really having the high burden. So, but what we are seeing now is that Nairobi is contributing 8% of the number of positive cases. So, which means that there is a transition of the disease from the coastal to the mainland, and the mainland in the capital city. So knowing how it can be challenging, we've seen it in Kinshasa, we've seen in Freetown, in the capital city. At some point, the increase can be quite exponential. So that's why also, as the IMST will intensify the support with a country visit, but also technical assistance and other support to ensure that we have an adequate surveillance that can go along with the vaccination. The country is planning to start the vaccination around the 6th of September, or around there. So it's critical. Is it the 6th? The 1st of September, thank you. And the vaccination need to go hand in hand with the surveillance. So they need to have a proper geolocalization so that they go exactly in the area where the cases are. So now going to the issue of the challenge with HIV and the USG financing, So we are optimistic because we see some very positive indicator from the US government. We've mentioned the authorization of the shipment of 219,000 doses of vaccine. We've also seen the fact that the PEPFAR is being rethought to carry on. So we are monitoring that one, but also we are engaged in the conversation with the US government. So once the things are a bit more clearer, we'll be happy to communicate with you on how it will impact the HIV management in the continent.
Thanks. Let's take the next two questions. I have one here from Moraitu Koroma. The question is, I would like to find out the latest developments on research and development of tuberculosis vaccines in Southern Africa, the progress of the HIV vaccine trial in Zimbabwe and South Africa. That's the first question. Then we have another one from Ishtak. The question is, how can we improve our surveillance system against diseases and how to solve our emergencies without international support?
So thank you. So for the first question on research, specifically on TB vaccine and HIV vaccine in South Africa and so on. Though the stock taking conference is around Mpox, so we are also enlarging the conversation on how we can monitor those studies, but also ensure that we have the proper research uptake. So we'll make sure that next week, once the colleagues involved in those supporting those activities will be able to give you a proper feedback. So how to improve the surveillance without the support of our partners? So the biggest question is how to ensure that the response is autonomous. The first one is in terms of domestic funding, to ensure that there is a higher investment of countries in the response. I was in Sierra Leone, as mentioned a few weeks ago, and Sierra Leone has invested 1.7 million in the Mpox response, which have not been the case in the past. And that money has been used and is being used to really boost the surveillance. And by surveillance here, we mean the community-based surveillance, where you have those community healthcare workers who will go household by household to ensure that they actually find the case or the suspected case and ensure that around those one, they implement the vaccination. So bringing all the two components together is what have an impact. So the second thing is also the professionalization of that community-based surveillance. The target by Africa CDC is to have 2 million community healthcare workers by 2030. As per now, we are around 1 million, so we are halfway, which is good. And we believe that with the outbreak, which has shown the importance of the community-based surveillance, but also the importance of the digitalization of that surveillance, meaning that those actors of the surveillance in the field, equipped with the right tool, the phone, but also the right DHS to tracker, allow us to have a real-time monitoring. So having the tool, having the workforce will allow us to have a sustainable way of responding to those outbreaks. So once the domestic funding are there, great. If we manage to have some support from our partners, our ally, then therefore it will be catalytic. But every country should have a national fund to respond to those outbreaks so that before the international community support, they are able to implement a quick response, because it's always easy to respond when you have few cases than when the number of cases are escalating. Over.
Thank you, Prof. Next, we have a question from Amiable of Mongbe, Africa. The question is, a key step in preventing Mpox at its source is to address the handling and consumption of bushmeat from potential animal reservoir. What control measures have been put in place to contain the infectious disease in hotspot areas in Africa? That's the first question. The second one comes from Clara of Legacy Media. The question is, what are the measures Africa CDC has put in place to fight against NCDs, especially on clients who are on antiretroviral drugs? Observing many clients are suffering either diabetic or hypertension or both, having noted most from African countries rely on aid. Back to you, Prof.
Yes, thank you. Thank you so much for those critical questions. And it's glad to have some questions that move from the infection to the NCD. So we'll be happy to respond to that as well. So in terms of the key step in countries that handle bushmeat. So I mentioned that in the presentation that in DSC that we found some DNA for Mpox in rats, in squirrel, which was already found also in Ivory Coast. We know that in Central African Republic as well, there has been the DNA found in some of those animals, which we believe are the reservoir. And it's also important to highlight that this disease of Mpox is endemic in those countries, and that it's One Health. So it's coming from those animals moving to human. So the first point is, if we go within that community, understanding that those animals are part of the culture, are part of what they are eating, asking them to just stop might not be what will work. So it goes with a strong community engagement, communication, education. So in what they need to do to avoid being contaminated by the meat that they handle. That's one in terms of prevention with the RCC. The second point is, we have been talking about vaccine to respond to the outbreak. But in our plan, there is also a component where we want to reduce at least by half the Mpox is in endemic countries. So what we are working on as we're moving into the transition is how we'll manage in those countries to increase the proportion of people who are immunized against Mpox. So in those places where there has been and there is still some transmission in Car, last week there was still some case in Baiki, which is an area where we have those spillover from animal to human. It will be important to see how we can which population we can target and how this vaccination can enter in the routine of those countries. But this also leads to the issue, the agenda of local manufacturing. Because if we really want to well protect those populations, we need to be able to have our own vaccine, because today a vaccine is between 65 to $100, which is quite expensive. So it will be critical to find the way with different vaccine, the Emirates vaccine and other, but also to have the local production so that we can make it available and therefore be able to use the vaccine as a prevention tool in those endemic regions. So for the NCDs, the simple question I will provide is in the Africa CDC new financing era, the domestic funding. This is the most critical. How countries will manage to leverage some funding to address the challenge in the population, domestic funding, but also the innovative funding with the partnership with some companies like what Africa CDC has been doing with Ethiopia Airways, or what DSC is trying to implement here with the partnership where they will get some taxes on tobacco, on alcohol, to create a fund that will be able to invest on those diseases. We are talking about the NCD, but we can also include the tropical neglected disease, which we will include sickle cell disease, where you have few partners willing to invest while it's a big issue for our population. So all in all, it will come back to our leaders to ensure that we have the right and appropriate way to leverage some funding and therefore implement the management of NCDs in our communities.
Thank you, Prof. Let's take the next two questions. We have one here on the progress. The question is, what is the progress in the malaria vaccination this time? That's the first question. And then the second one is from Sheriff of Gambia News. The question is, as Mpox declines, what are the mitigation strategies by Africa CDC as part of efforts to help member states in the drive to emergent public health emergencies facing the continent? You can take those two, Prof. Back to you.
Yes, thank you. I will start with the second one on the mitigation. So, as you know, we started the response to Mpox following the facts that was declared on the 13th of August. And with that, we initiate Preparedness and Response Plan 1.0. And in March, we developed the second plan, the 2.0, which focused on intensification, integration, and legacy. So now we need to move further in terms of integration and legacy on how the countries that will therefore be significantly equipped. They've been supported by the IMST and the partners, but now that we see some great progress, not only on the number of cases, but also on the capacity of the countries, the NPHI and all the countries to manage by themselves the outbreak. So what is needed and what was requested by the partners, even when I was recently in Sierra Leone, was to have a guide, to have a plan for the transition, how the member state will ensure the transition in terms of surveillance, in terms of detection, in terms of management of Mpox in the country. So those are the key points. Now, going to the question of malaria vaccination, you know, we've been waiting for the malaria vaccine. The first result was showing an efficacy of 30%, which means that out of 10 children, 3 will be protected, will be fully protected. But we are happy to see that there have actually been an increase on the number of countries that have rolled out the vaccine, and we are closely following up the impact, the effectiveness of the vaccine in those countries, so that Africa CDC will use his leveraging power to increase the number of countries that will implement the vaccine there. Now, the other point where we always come back is the affordability, the accessibility of the vaccine, because the vaccine is still quite high, $5 per dose. We need to move with the GSK and all the manufacturer to reduce the cost, but also pushing our agenda of the local manufacturing, because we believe by reducing the local manufacturing of those vaccines, we'll be in the better position to increase the availability, the accessibility of the vaccine for our communities.
Thank you, Prof. We have the last 2 questions here. I have one that asks, can you elaborate on the home-based care that you have mentioned? Is this a viable strategy? Is this not a measure that poses a risk of the disease spreading, perhaps like what happened in Sierra Leone, as you mentioned in the previous briefing? And then the other question here is, what is the situation of Mpox in Nigeria? Back to you, Prof.
Okay, thank you. Okay, so the home-based care, it's an inheritage from the COVID, the time we were responding to COVID-19 in the continent, and where not only Africa, but globally, we realized that with the high number of cases, we were not in the position to isolate all the patients in hospital. So based on that, we've decided to support countries on the implementation of home-based care, which means that when a patient is positive for Mpox, he or she will be isolated within the household. So the one room will be identified where that person will be kept, and then we'll have a community of care workers who will ensure a follow-up during 21 days. Either they will be able to come there every day to check for the symptom, the temperature, and so on, or at least they will be able to give a call every 2 days, call every day and come every 2 days to ensure that the patient is doing well. But the challenge, as you mentioned, we've learned also from the beginning of our mistake. The challenge we realized that is we can have someone who is isolated at home, and then you see the person in the market, you see the person going to church, you see the person going out, and while they go there, they continue to transmit the disease, because also you have the stigmatization that is behind. So what we are strongly recommending, and that has been a very good example in Burundi, that is currently happening in Sierra Leone and some other country, is really to ensure that we have enough health facility to ensure that those health facilities, the patients are well isolated. Because if they are not isolated in the health facility, then we'll keep on having the transmission. However, is also this come with some caveat. The first one is that if you isolate people, you need to provide them holistic care. Holistic care include also the food. We've seen in Kenya, for example, where some patients were running out of the hospital because they did not have the food for them, and also for the ones that are supporting the population, the caretaker. So the situation in Nigeria, so as per today, the vaccination is really one of the key points which they're starting this week. They've taken long to be able to implement that vaccination. One, because the number of cases were not increasing; they were quite stable. Two, because Mpox has been circulating in the country, but we are glad to report now that they will really push for the vaccination with the 16,000 dose of vaccine that they do have right now. So that's a very good news for Nigeria, and we will keep on following it. So still on the side of vaccination, we know that we have very few doses of vaccine that are available. We mentioned the 219 doses from the US government, 59,000 doses that will be that has been acquired by Gavi, but that will not be enough. And that's why we are supporting as IMST, which is the WHO, Africa CDC, and other partners, the use of fractional dose, which means one dose will be able to vaccinate 4 to 5 people, depending on how they are used. And we are glad to see that country like Uganda, but also Sierra Leone now, Liberia, sorry, through the NITAC. The NITAC is the body that recommend, advise the Ministry of Health on how they can use the vaccine. So those one are recommending, are supporting the Ministry of Health for the implementation of those vaccinated doses. And on the other side, we have partners, UNICEF and others, that are making sure that all the tools, the syringes that are different, are also be procured so that all the country has all what is needed to implement it. But it's important to highlight that this is not new. It has been used for the vaccination of TB, so country knows how to do it. They simply needed to have some evidence, which they do have because it has been used in other countries, and now the logistic that is needed to implement that vaccinated dose of Mpox vaccine.
Thank you, Prof. And with that, we have come to the end of the weekly briefing this week. I'll hand over the floor back to you for your closing remarks.
Thank you so much, Director Margaret. Thank you for the colleagues who are also there physically, those who are in countries. And to end, I will thanks to the journalists. Once again, you make us accountable to you through your question, which in many times challenge us, accountable to our communities, accountable to our leaders. And you ensure that we have a clear transparency on the way we implemented the response to Mpox and other outbreaks. So we are glad that next week we'll have the launch of the task force for cholera, but also the new continental preparedness and response plan for Africa 1.0. And we'll be happy to see you next week at the same time. Thank you.